Yeah, I think every patient now with an advanced adenocarcinoma of the lung needs to have genetic interrogation or comprehensive genomic profiling. There are too many mutations now that we can act upon with targeted therapies, and as such, we do a 50-gene panel by an ion torrent AmpliSeq platform. So we test for EGFR, we test for KRAS, we test for BRAF, and other genes in that panel, in that AmpliSync, the ion torrent panel. We also do ROS and ALK by FISH to look for those rearrangements. But at the bare minimum, every patient with an advanced lung adenocarcinoma needs to be tested for EGFR, ALK, ROS, and BRAF. And I would say that the list is going to grow even longer in the next 1 to 2 years, where we're going to need to be doing more and more testing. There are rare mutations that are potentially predictive of efficacy of other targeted therapies, so we need to keep that in mind. But clearly EGFR, ALK, ROS, and BRAF are the ones that need to be tested up front in all patients. A large majority of patients, if you include KRAS, who have lung adenocarcinoma, have a driver mutation. That's probably 60 to 70%, 60% of patients have some sort of driver mutation. It's a little bit different question if you ask what proportion of patients have a driver mutation that you can wed to a targeted therapy, and I think that's what's important. So if you look across the board, about 20 to 30% of patients now have a driver mutation that we can act upon with a targeted therapy. That still leaves 60 to 70% of patients that don't have an actionable mutation, in which again we can deliver precision medicine. But I would say again, the list is growing longer of rarer yet actionable mutations in lung adenocarcinoma. That's outside of EGFR, ALK, ROS, and BRAF. We have MET exon skipping 14 mutations. There are NTRK fusions that may be predictive of a drug called entrectinib. So the list is growing longer. We need to be mindful that things are changing rapidly, and we need to stay ahead of the curve and stay on top of the data. So PD-L1 testing now is the standard of care, not only for advanced adenocarcinomas, but also squamous cell patients with stage 4 disease. And this was based on a trial comparing single-agent pembrolizumab, Keytruda, to chemotherapy for patients that had a PD-L1 tumor proportion score greater than 50%. And in that trial, there was a benefit in response rate, progression-free survival, and overall survival for single-agent pembrolizumab. And as such, based on that trial, every patient that walks through the door needs PD-L1 testing. Every patient that has advanced non-small cell lung cancer, whether they be squamous cell or whether they be adenocarcinoma. If a patient has a PD-L1 score greater than 50%, then they warrant single-agent pembrolizumab based on that trial. And this gets into a larger question of, well, you have to do genetic testing and you have to do the PD-L1 testing. And it gets to a whole issue of what's called tissue stewardship, where you need enough tissue not only to do the genetic testing for adenocarcinomas, but you also need enough tissue to also do the PD-L1 as well.